Hello, good evening, and welcome to 13th session. So today is super vessels of gut. That is all the vessels, right? All the major vessels, and it will give you a very good clarity that how the entire distribution is there. The best part is you know almost 90% of the topic of today, right? Because we have discussed it several times. So it would be a sort of very comfortable revision plus few new points. Uh, if IgA antigen, so because then it goes straight away for the this the treatment. Because if there is any of the antigens detected, send a mail to me because it is a very lengthy answer, right? Okay, yeah. See, there were few queries, right? I just came across there were few queries from yesterday's topic. I got few mails. One was like, say this, when shall we start the physiology part? We'll definitely start, right? Just give me some time. Definitely we'll be starting the physiology part. And you can just let me know because what timing should we keep for the physiology, right? If we start physiology, then what should be the timing? Whether we keep it in the morning or say, I won't be preferring very late night. So right? So just let me know that if we are planning it, to then is morning okay? Regarding the thorax, when shall we start the anatomy of thorax? Well, I got 4 5 mails for this. I would just say one thing. Actually, after completion of our abdomen, my wish is that straight away we start with the head and neck or brain because they are pretty good, pretty complex and good to learn. Say regarding the thorax, in thorax as such, if you see now, so heart and the lungs, right? They are there. Now there is a complete series on heart which we have already taken. So if you go for that, right? If you go for that heartily heart, so most of the heart would be covered in that. and and in lungs, well, if you wish we can have say 2 3 sessions on lungs and plus the azygous system, so it would be a matter of about 1 week. We can plan that, but not actually the entire thorax because it would not only that it would take more time, but will be delaying like head and neck or the brain, right? So yeah, that's what I was telling. That head and neck is actually pretty complex. So you will really like it. Uh Other subjects, that means see, it's like I'll be starting with physiology, and once we complete say anatomy, then it is like pharmacology because pharmacology is also one of the subject which actually means I'm telling we because I used to forget it very much, but then when you learn the actual basics of it, you find it very interesting. It is like mathematics, right? So this was the thing. Now we come to this one important query, and I really checked it, and so it's like I'm not insulting anyone, but yeah, if that was written in that book, right, it is not right. Say I got a mail in which it was said in VDC the portal hypertension is mentioned when the pressure is more than 40 millimeter of mercury. Now see, 40 millimeter of mercury, right? That is just too much. That is actually too much. I just said that it is like more than 12 millimeter of mercury, so that is actually considered as portal hypertension. But say when I have been asked for this question, so now I am telling you bit in more detail that where exactly you define that yes, this is a patient of portal hypertension. See, it goes like this. Consider this is liver, right? Very schematically I'm drawing, and over here something which is going out, that would be the hepatic vein, right? This hepatic vein would be connected to IVC and it would be connected to right atrium. ठीक? Portal vein is going in, right? So that's the portal vein. When you say, and say in the portal vein, the normal pressure is about 5 to 10 mm of mercury. I'll tell you. So yeah. So portal vein normal pressure is 5 to 10 mm of mercury. Now when you say portal hypertension, right? So portal hypertension means that the pressure in the portal vein should be minimum 5 mm more than the IVC. You're getting it? Because see, when the pressure in the portal vein, right, pressure in the portal vein, it should be more than the pressure in inferior vena cava, correct? But how much? By at least 5 mm of mercury. Then it is considered as, yes, this is actually the portal hypertension. If you are measuring it with a perspective of hepatic vein, so then if it is more than about say 1 to 4 mm of mercury, right? So then it is considered as portal hypertension. Now over here we are comparing it with hepatic vein, right? So see, as you progress, the blood column will become bigger and bigger. It will become bigger, sorry. It will become bigger and bigger. So when it is hepatic vein, to 1 to 4 millimeter of mercury pressure, it should be more in portal vein. Where if you are measuring in IVC, so whatever the pressure is in IVC, if in portal vein, it has to be more by 5, right? And when you are comparing it with the right atrium, so in portal vein, that pressure should be minimum 6 mm of mercury. When this thing occurs, that is actually what is called as the portal hypertension. Okay, so let's proceed with our today's session. What we shall be talking about is, say, one very simple thing, as we said, that it is the foregut, midgut, and the hindgut. Correct? This is how the entire system GUT is divided. And for the arteries and for the veins, right? It is simple as that. Or let's change the color. For the arteries, it is celiac trunk. Today we'll be watching it in bit more detail along with its all relation, right? For midgut, it is superior mesenteric artery, and for hindgut, it is inferior mesenteric artery. When it comes to vein, there is only one change, and that is over here it would be the splenic vein, correct? Then rest is superior mesenteric vein and the inferior mesenteric vein. That's it. That's how the entire distribution goes. So now you need to know only this much, that foregut is from where to where. That you know it pretty well, right? Because that is still D1, right? So stomach and D1. This will be from D2 to transverse colon to third, right? Makes sense, right? So that is midgut, and in case of say hindgut, it is transverse colon, rest of the 1/3, right? Rest of the 1/3 to the rectum. So that is the hindgut. So these vessels, they will be giving the branches with the similar names. That's why it would be so easy to understand the whole concept. Okay. Say this is like, all of you just let me know that what should be the convenient timing for the physiology, right? So that I'll plan out accordingly and will definitely let you know, right? Okay, so this is like that, this is the basic. And another thing, or some keywords, say whenever we'll be talking about portal hypertension, right? Portal hypertension, that means when the pressure is increased, there would be three major things. One, what is called as the esophageal varices, right? Esophageal varices, which can lead to hematemesis, that is blood in the from the mouth, vomit, esophageal varices. Then it can be caput medusa, right? Caput medusa, and the hemorrhoids, hemorrhoids, or what is called as the piles. Why over here? Because these are the areas where there is, right, where there is, by the way, just ignore this figure, right, because we are writing on the figure, so nothing to be associated with it, because these are the areas which are having porta caval anastomosis, right? Anastomosis. What exactly we mean by portacaval anastomosis? Porta means portal vein, cava means that is inferior vena cava, right? So it is where the portal system, that is hepatic system, and the systemic system, they are having anastomosis, right? So that's why all these things happen. Plus, I would like to add one more thing. In this, you must add, right, that it is the bare area of liver, right? Bare area of liver. Just keep it in mind. That is also where there is portacaval anastomosis, right? So this much is there. 7:30 a.m. Well, I have to change my exercise schedules. Anyway, so here it is. We start with our first one, right? The celiac trunk. Now you'll find that many of the figures, right, they are from the popular book, so that it becomes easy for you. Books, they are very good, right? When someone asked me about that, should I depend entirely on Gray, I said that no, don't do that. Definitely it's an awesome book, but very difficult to digest. So one more question was asked, that what we are studying right now, is it sufficient if we remember everything? If you remember everything, yes, gentlemen, it is absolutely sufficient, right? There won't be any trouble. But yes, still you need to go through the books, so that, because see, it's like human errors. If I miss something, so you should not suffer. My purpose over here is, as I said, to take you on runway and to give you a good lift. Then you can easily fly. To make your concept so clean, so that when you go into the books, you won't be finding any trouble, right? Okay, so here it is, like say celiac trunk. That's the celiac trunk, right? So celiac trunk, that's what gives supply to say lower esophagus, right? Lower esophagus, and then say stomach, and D1, that is the first part of duodenum. Plus it will give supply to liver, right? It will go to that splenic artery, so it will supply spleen, and it will supply pancreas, right? So that much is the role for of say celiac trunk. Now see here the level is shown. So celiac trunk is emerging between T12 and L1, right? L1. So this is the thing which we must know. There are other supramesenteric, renal, gonadal, abdominal, etc. Hang on, right? They will come. Meantime, we just see this, that inferior phrenic artery. Yes, we just put a tick. We saw that inferior phrenic artery, right, when it was supplying to the diaphragm, right and left. Okay, this is important. Yeah, this is important, that many times the relations, that what exactly is the location, and when it is enumerated, it becomes very difficult to digest, right? So here these are the relations of say celiac trunk, right? Now, because this is like a longitudinal section, so it means this side is anterior and this side is posterior. I'll make the things comfortable to you in a way that I'll just write down that where to start. Here it is, the celiac trunk. So that's the point. Celiac trunk, right? Right in its front, right? There are structures, because we know that to watch that celiac trunk, we had to actually push the stomach. So it means it is just behind the stomach, right? Now, it cannot be just behind, because just behind the stomach, so there is lesser sac, right? So let's start with stomach. Stomach is in front, right? This is anterior. In anterior, so there would be even the lesser sac, right? Lesser sac formation. So over here on the top, there would be liver over here. So between liver and stomach, there is lesser omentum. So that is the lesser omentum over there, right? So this part is pretty easy. So, and just a minute, let me have that color. Okay, all right. So this is stomach is good, lesser omentum is good, lesser sac is good, right? So far good. This entire portion, that would be retroperitoneal, correct? It would be behind the peritoneum. So this is a retroperitoneum. In retroperitoneum, first thing which strikes is that body of pancreas, right? So that's our fourth point which we see. And today we'll be watching in more detail that underneath this body of pancreas, right, there is a splenic vein. So that's fine. This is the area. This is what we want to have a look at it. Other structures, we won't worry at this point of time. Just this is okay, greater omentum, right? Because that's how we have studied it in more detail. Lesser omentum, and then this is the greater omentum, which will be going down, and then it will take turn. It will come to this transverse mesocolon, etc. Right? Things to be added in this. That is on the right side, right? We are adding it in this figure only, right side and the left side. Now see, it is the celiac trunk is like this, and both the sides there are diaphragm, and in diaphragm there were crus, horns, right? So on the right side there is right crus of diaphragm, and on the left side there is left crus of diaphragm. Fine. That's the location of celiac ganglion. Celiac ganglion, as we said, that when we'll complete our normal routine anatomy, then there would be one session which would be only for these ganglia, that how these ganglia they are interconnected with each other, right? So that's how will be. So right now you just need to believe me that there is a right celiac ganglion and there is left celiac ganglion. As such, they both the sides, they are pretty musical, right? Quite similar. So celiac ganglion, right? So that is done, right? Crus means horn, right? Crus means horn. So if you say when the diaphragm was there, so like this, right? These are called as the crus which are attached. Actually, if you remember, I even showed you these crus, that where exactly are they located. No issues, right? In any case, they will come again, right? Just in a day or two, again it will come. So at that point, I'll show you in real images, right? Real dissected images. So here it is, left crus, left celiac ganglion, right celiac ganglion. And if we want to put the organ, so on the left hand side, we need to put stomach, right? And on the right hand side, none other than liver. Now we can be more specific in that because stomach, that is only the top portion, right? That is only the top portion, and that top portion is called as the cardiac end. So not the whole stomach, we are just telling that on the left side of celiac trunk there is cardiac end of stomach. And in case of liver, it is that famous caudate lobe, right? Caudate lobe which was irregular lobe, right? Because other lobe was very regular, and that one is quadrate lobe. Very right. right? That is the quadrate lobe. So these are the relations of celiac trunk, right? Most important that what is anterior to it, you now know it very well. And because it is emerging directly from the aorta, so who is behind it? Well, aorta itself, right? So that's the only thing. Regarding right and left, you need to know these many structures. Okay. Here comes, this is not requiring any explanation. You are master of it. Celiac trunk, right? Then left gastric artery, that's right. Common hepatic artery, good. And the splenic artery. And then the pancreas is over here. And splenic artery is tortuous, right? Even this image, you know it so well. Because in this image, we just need to see following structures, right? That from celiac trunk, that who is forming that arcade? Left gastric artery, right? Left gastric artery, and here is the right gastric artery. Right gastric artery and left gastric artery, they are making the arcade on the lesser curvature. And on the greater curvature, it is the left gastroepiploic artery and the right gastroepiploic artery, right? Rest, that is all self-explanatory. No problems. We'll see that, right? Let's see, it is the left gastric artery that is main, and it is giving branches to, say, this esophageal branches, those short gastric arteries, right? All those things, they are branch of, say, left gastric. Similarly, in case of, say, common hepatic artery, which is one of the branch of celiac, right? And from common hepatic, right, it takes turn. One is the proper hepatic artery, which will be going up, and then it gives this gastroduodenal artery, right? Gastroduodenal, and this gastroduodenal then later on will divide to that superior pancreaticoduodenal and the right gastroepiploic. I mean, here, right? So this is this one is superior pancreaticoduodenal, and this is right gastroepiploic, which will be forming that anastomosis. One extra thing, that is the cystic artery. Don't forget this. This is the cystic artery, which is emerging from that hepatic, right hepatic, right? In fact, it is the right hepatic, because say it divides into two, right? So it is the right hepatic, and then it goes for the gallbladder, right? Now, say it is absolutely fine to demand something, right? I got one very interesting mail, and it was said that every time, if possible, you just simplify those blood supplies. That is when I write like just a schematic diagram, right? No worries, gentlemen. That's absolutely fine, right? It is your right to demand, and I don't have any problem, because I know actually I used to learn and remember like that only, right? So here it is, the celiac, and what you can do is when I'm drawing, right, I'll speak with a slight delay. So at that point you can go for a live revision. So it's like when I draw this, right? So this is yes, that is, you'll say that is the splenic, right? That is the splenic artery. Then we'll draw one more, which is on this side, and that would be, that's right, common hepatic artery. This common hepatic artery will divide, right? One which will go, we'll call it hepatic or the hepatic proper, right? It is the hepatic artery, or to differentiate, we can call it proper hepatic, but only hepatic is sufficient. And then one which goes like this, and that is what? It is right gastric, very right, right gastric. And this right gastric will be communicating with one more, right, which will be going up, and it goes like this. So this we are dealing with left gastric. Okay, so that way, this is 1, this is 2, this is 3. These are the 3 major which are emerging from cilia. This hepatic, it divides into 2 parts, right? The right side and the left side. There is one very fine thing to remember, that it is the right hepatic artery, which is giving branch to, which is giving cystic artery, right? Cyst means bladder, right? So this is where it is giving supply to gallbladder, right? Okay, so this much. Now there is one more branch, so I'll change the color, right? This one more branch which is going down, right? And its name is gastroduodenal, right? So both alphabets, they will be carried individually, so it will divide into like this, and this is, say, G, right? So this is gastro, right? Epiploic. So that is gastroepiploic. But which side? Because there will be another gastroepiploic. So because this is right side, so it is right gastroepiploic. And regarding this D, that goes towards the duodenum. So that is pancreatico duodenal, right? But this is coming from the top, so this is superior, as there would be one inferior also which will communicate, right? So this is done. Only one which is left out, that is, say, this one, right gastric and left gastric, that is happening at lesser curvature, and this big thing, it should happen at a greater curvature. So only one is needed, and that thing will come from splenic. So splenic is here because there is no one else, right? So there would be one which will be coming, okay, this color, okay, right? And that is left epiploic artery. Draw this thing 3-4 times, right? So that it is completely set in your brain. And the best time is, say, whenever, I don't know whether you guys go to canteen or not, but we used to do that, right? In canteen, right? We used to draw, chalo, let's draw this, and you draw. That way you'll remember it for a very long duration. Okay. Anyway, you can draw it anywhere. Just take a small piece of paper, draw it, and you have understood it, throw away that paper. That's it. It is now stored into your brain. But do draw. Right? One more thing, let me know for when you want to set the test exam, right? But I know your exams are already, say, due, right? Within, I think, on 4th or 5th it is starting, na? So just let me know when you wish to go for the our exam, that is for this abdomen, right? So don't want to put burden on you, but say if we'll go for that exam, you will be happy, right? You'll like it. And actually it forces you to study a bit more. Okay, so here it is quickly. This is celiac trunk, superior mesenteric artery, and where is inferior? Here is the inferior mesenteric artery, right? So these are the major arteries. And then, say, regarding this right kidney, left kidney, right? I'll not insult you. And this is the portal vein, right? That's the portal vein, and rest of the things like hepatic artery, umbilicus, that's okay. And you know it very well that it is the aorta which divides into that common iliac, and it divides into external and internal iliac, that is intertubercular plane. Rest is all known. This is splenic artery, that is also known. Left gastric, all known. Pretty simple figure, right? Not much. We now learn our superior mesenteric artery. Now there is some heavy description of this artery. I have just tried to make it a bit simple. Right? Superior mesenteric artery is the artery of midgut, right? It is artery of midgut. You know what is midgut. So I'll just write D2 to transverse colon to third, right? Now if we write this much, so then you should be able to understand, right? So many structures, every structure would be supplied by this superior mesenteric artery. But, well, some of the structures, right, they have got mesentery, some of the structures they don't have got mesentery, some are in front, some are in back, right? Things are like that. So how it goes? superior mesenteric artery is divided this way. One above the root of the mesentery. Now, do you remember root of the mesentery? Root of the mesentery. What was root of the mesentery? We said that the mesentery is attached at a small area, but then it is thrown into folds 30 times more, right? So it was just on the top, that D3, right? Just at the terminal of D3, and then all the way, right? It is going toward the cecum, right? Towards the cecum, root of the cecum. So that's the root. That's the root of the mesentery. Right? That's the root of the mesentery. So superior mesenteric artery above the root of mesentery, right? And second portion, that would be within the root of the mesentery, right? Within the root of the mesentery. Why so? Right? Why so? Because when it is above the root of mesentery, it means it will be supplying all the structures which are before this colon, right? Because this is the portion where it will be supplying all those organs, anterior and the posterior. Right? In anterior, right, there would be, say, pancreas, right? Pancreas, spleen, right? Posteriorly, say, aorta. If you see its relation, right, then there would be, say, left renal vein. These are the relations, right? How they are related, right? I'll draw it over. I'll write it over here. Relations. So left renal, and we'll see in fact this in pancreas, that uncinate process, right? Uncinate process. So when it is above the root of the mesentery, anteriorly you'll find that pancreas and actually the splenic vein, right? Splenic vein, because it is just in the root, and posteriorly obviously that aorta, kidneys are behind left renal, and the uncinate process. What exactly I'm talking about? Let me draw a small simple figure. This is like it. This is like it. So to be specific, pancreas, the body, right? So here is how this particular superior mesenteric will go. Superior mesenteric would go. In its anterior portion, there is pancreatic body. So that means this artery has to be behind, right? It has to be behind the body of pancreas. Then pancreatic body would be in front, splenic vein is in front, and then in the back side it goes like this, right? So that is where the pancreas uncinate process, it goes into its posterior relation, right? Duodenum, third part, right? Because it is going like this, and we know it so well that that's the duodenum third part. So this is D1, that's the D2, and this one is D3. So D3 is behind now, right? So here, this is how superior mesenteric is going to say travel, right? Now when it is within the root of the mesentery, right? This is interesting. Now it goes into the root of mesentery, because that's where it will be supplying all the vessels, means I mean all the say loops. It would cross two important areas, right? We'll just see the figure also. Inferior vena cava, and plus our very famous, very popular muscle, psoas major, right? Right psoas major. And from here onwards, it is also always with superior mesenteric vein from this point onwards, right? Let's see. say this is superior mesenteric. This is superior mesenteric, right? So that's the area of focus for today. From here, as it goes down, so now you know that say this would be the root of the mesentery, right? So above and below, now this is about the below part, where it would go. First thing, it will give this middle colic, right? It is giving this middle colic, right colic, right? All these branches, because they are going to colon, right? Watch for this. Don't forget this. This is that inferior pancreaticoduodenal, right? Inferior pancreaticoduodenal, as it will be meeting that there was superior pancreaticoduodenal, right? Which was part of gastroduodenal, right? And then this was going right gastroepiploic, and then over here it was the superior pancreaticoduodenal, and here is the cousin of that superior pancreaticoduodenal, and that is inferior pancreaticoduodenal, right? This is just for the reference, right? Then rest of the branches, jejunal and ileal branches, that's all okay, right? These are all jejunal and ileal branches. Point to remember is this. This one is ileocolic, right? Now this ileocolic is here. That's the ileocolic. This ileocolic divides into two parts. One which is going above, right? And second which is going below. So it is ascending and descending, right? So ascending and descending. To whom it will supply? Whosoever is near. So this ascending will supply ascending colon. Ascending colon. Descending, all the structures whatsoever are present over there. So it would be cecum, then appendix, and the terminal ileum, right? Only the terminal ileum. Terminal ileum. So that's how they are distributed. Okay. Celiac trunk, known, aorta, good, body of pancreas, splenic vein just underneath it, and say this one is our superior mesenteric artery. And in this superior mesenteric artery, just confirm this. We just saw that yes, it is like uncinate process will be behind, third part of duodenum will be behind. These are schematic diagrams, but now we understand that what it really means. It means very simple. It means just this what we talked about, right? It means this, that here is the uncinate process, yeah, that is behind, an uncinate process, entire pancreas within the C loop of duodenum, so that would also be behind. So this is perfect, this makes sense. So that is what we are watching over here, that uncinate process and the third part of duodenum, they are behind, right? And inferior mesenteric artery is also shown, but right now we are not talking about it, right? Okay. Yes, see this, right? Completely fine. Duodenum, yes. So that would be our D1, D2, and this one is D3. In D3, right? This is superior mesenteric vein and the inferior superior mesenteric vein and the superior mesenteric artery. They all are passing in front, right, of the D3, and the uncinate process, right? This one is uncinate process. Uncinate process. And this one is body of pancreas, right? Body of pancreas. And the root of mesentery, that is what we see. That's how it is connected. Okay. from jejunum, as we travel from jejunum to ileum. Travel from jejunum to ileum. Recta means straight, right? These are the vasa recta means vessels which are straight. Arcade means that they are in turn. So this is what is called as the arcade, right? And when they are like this, so these are like straight vessels. Straight vessels. So they are vasa recta. Points to identify or to know that when it comes to this top portion, right? When it comes to jejunum, see the inner part, right? Inside, large and closely set circular folds of mucosa, right? And then there are few solitary lymphoid follicles. There are few, right? Solitary lymphoid follicle. And if you see the vessels which are into the mesentery, and actually we have seen this thing, right? By lifting that mesentery. So there are about 1 to 2 arcades and there are long vasa recta. Now when it comes to say ileum, right, over here it is the ileum, and in ileum identification is that there are short vasa recta and there are more arcades, right? More arcades. So it is spread across. And inside there are aggregated lymphoid follicles. So many lymphoid follicles they are there. So these are the important two identification marks. Okay. So here is superior mesenteric vein, right? Superior mesenteric vein. So this superior mesenteric vein, it joins hands with splenic vein to form portal vein, right? That's the only thing which we need to see. But apart from it, just watch for a small area just behind the superior mesenteric vein, and later on portal vein. Behind there is big boss, this inferior vena cava is sitting, right? There was one more question, that in one of the section, right, when it was shown that we actually saw that thing in the dissection, that just behind the liver on the dorsal aspect we saw that yes, a big, very nice inferior vena cava is there. And then we removed that inferior vena cava to see those hepatic veins. Do you remember that? Right? To see those short and long, those hepatic veins which were draining into the inferior vena cava. But because this is the liver and right on just dorsal aspect, that inferior vena cava is there. So those vessels, they are directly draining into it. So if we really want to see that hepatic vein, we have to actually peel off. We have to remove that inferior vena cava. So we cut down that inferior vena cava and then we saw that yes, those hepatic veins, they were there. True. But when it comes down, right? So obviously the relation with the liver would change, right? Because liver is a big structure. So that association is only on the top where it is where the hepatic veins, they are directly draining. Otherwise, so it is a big vessel, right? So over here, left renal and right renal, that's what it is giving, right? And this is superior mesenteric artery. Idea is, remember this part. Topmost is superior mesenteric artery, then the left renal vein, right? And then the aorta. So actually, if you see, this renal vein is in between. In front there is superior mesenteric artery, and the back there is aorta, right? And this was the reason when we wrote that in superior mesenteric artery, right? See, that's how the splenic vein is arranged, right? And this one is left renal, right? See the left renal, right? Left renal is in the posterior portion, right? It is just behind left renal vein. Yeah, that's right. Left renal vein, right? It is into the posterior relation. Got it. So aorta is yes, posterior, right? Left renal, yes, it is posterior. Pancreas uncinate process, definitely yes, right? Because it is behind. So these are the structures. Now things should be pretty clean. That who is behind, who is in front. The superior mesenteric artery, right? It's very important. So that's why it is taking a leading role and it remains in front. Right? Renal is supplying, right? It is draining just the kidney. Aorta is kind-hearted, so that's why retroperitoneal sitting in the back. Right? Okay, so this is done. So superior mesenteric, now we talk about superior mesenteric vein, right? So over there, in case of superior mesenteric vein, there is right, its tributaries, right gastroepiploic vein, correct? Also, there would be inferior pancreatico-duodenal, right? And then there would be few other tributaries. Now, say for liver, we need to understand two important points. As we said that liver, it has got dual supply, right? One is from portal vein, and second is hepatic artery. Now, due to this thing, in case of hypoxia, in case if anything happens, lack of oxygen, right, hypoxia, the most sensitive organ to be affected is brain and the heart. Liver is quite resistant because it has got dual supply, and portal vein is supplying almost 70 to 80% of blood, right, of blood, total blood which is getting supplied to liver, 70 to 80%, but the amount of oxygen which is giving, that is mere 40%. So 40% oxygen is by portal vein, right? Because if it is vein, so it's not so that it is absolutely devoid of oxygen. No, it will be giving something, right? Regarding the hepatic artery is just supplying 20 to 30% of blood. But remember, 20 to 30% of blood, but see amount of oxygen it supplies, most of 60% of oxygen is supplied by hepatic artery. So that's the game, that in case if anything happens, right, but liver is quite resistant to this hypoxia because of such system, and as such liver gets tremendous blood supply, the tremendous blood supply, it is pretty high, right? It is in the range of 1.5 liters per minute. This is the rate at which it is getting the blood, right? So that's about the liver. Yeah. So now we see the major one. This is superior mesenteric vein, right? That's the portal vein. Here is the splenic vein. Splenic and superior mesenteric, they both combine together to form portal vein. Fair enough. But this portal vein is also getting, it is actually getting the blood from entire GUT, right? So splenic vein will be giving from foregut, superior from midgut, and it is this inferior mesenteric vein which will be draining into the splenic vein. So this is taking care of hindgut. So thus all the three are contributing and sending it to portal vein, right? So that's how it really goes. Let's see. Hindgut, that is from the remaining 1/3 of the transverse colon, that is the distal 1/3 of the, or the last part of the 1/3 of transverse colon, right? So inferior mesenteric artery over here, right? So this inferior mesenteric artery, if you see the branches, one is this ascending branch of left colic, right? Now this is left colic because left colic is supplying this descending colon, right? So there is ascending branch and the descending branch, as it is taking care of this entire descending colon, abdominal aorta. That makes sense. This is left colic, right, whose branches are there, and this inferior mesenteric artery, it continues as superior rectal artery. It continues as, right? So superior rectal artery is the continuation of inferior mesenteric artery, and it goes all the way to supply the rectum, right? So these are like sigmoid arteries. So if I just mark, see, these are the sigmoid arteries, then superior rectal artery, left colic artery, and its branches are ascending and descending. So now easy, right? Left colic is taking care of the colon, and sigmoid arteries, they are taking care of the sigmoid colon, and then artery itself, inferior mesenteric artery itself, continues as to supply the rectum, and that is superior rectal artery, right? Quite simple. This is marginal artery of Drummond, right? This is the marginal artery. Now this speciality is like that, see, as such there are specific vessels, specific branches for colon, this, that, everyone, but still there is a formation of this arcade. So this arcade, it supplies, it is like a backup plan, right? It is like a backup plan, and that's how they create this complete arcade, and this is called as the marginal because it runs at the margin. So this is called as the marginal artery of Drummond, right? And it gets branches from almost everyone, right? Say, so it is like, say, formed by, if we start with the cecum, so that is ileocolic, right? Ileocolic artery, right? Then as we proceed, this would be like right colic. All of them, they are by right colic, middle colic, so they are all from superior mesenteric, right? Then we have got left colic, yes, that is from inferior mesenteric, and the sigmoid. So that's it. So that's what really forms this backup plan, this entire arcade, right? And that is the marginal artery of Drummond, which is like a, you can say that it is like a backup plan. All right. So when we say now regarding the veins, the portal vein, right? Portal vein. There is one very interesting thing, and that is what is called as the streamline flow, right? It is called as the streamline flow. So in this streamline flow, we said that that's okay. This is the portal vein, right? And there from here it would be the splenic vein, and this would be the superior mesenteric vein, and it will form that portal vein. But there is something which is very interesting, and that interesting thing is that superior mesenteric, when it is taking the blood, right, it is like a car without the brakes, and it will start dug and without brake, and it will go, right? It will say, "Arey, there is left side also." He said, "No, I can't take turn," right? And that's the reason superior mesenteric vein, most of the blood of superior mesenteric vein, it goes into the right lobe of liver, right? So then there comes this splenic vein, right? Splenic vein is also a very enthusiastic driver, goes, and then, right? So it goes towards left lobe, left lobe. But in the process, in between, there are two small stations. So it will also supply caudate and quadrate. So it will supply them also. This right side will say, as such, I am supplying this big area, right lobe. So you take care of those small things. This arrangement, this is what is called as the streamline flow, right? Actually, it is not so that they are like completely separate, but most of it, right? As such, because they both are coming into the same vein, and this portal vein is pretty short. So that's why this streamline flow, it really occurs. I was expecting this thing. Something would come. No, actually, when say people are learning the driving, it happens like that. They teach, "Arey, come on, this is accelerator, right? This is clutch," and it really happened, right? And it really happened with one of my friend, right? He was learning how to drive a car. Somehow he was not knowing where the brakes are. So then when the instructor was shouting, "Come on, bhai sahab, brake maro," तो कहते कहाँ है ब्रेक कहाँ है? And it actually happened like this streamline flow, right? वो सीधी गाड़ी चली गई. So this is like streamline flow, right? Exactly. कि मैं तो अपने रास्ते चलूंगा. Another thing about this portal vein is that there are two systems which are communicating. There is one set of system which is from the gut, second set of system which is the liver. So all of them, they finally go into the liver sinusoids. Correct? Liver sinusoids. That's where they will go. And from liver sinusoids, after doing all the business, right, it will say, okay, this is like, say, the leftover thing. Hepatic veins take this thing, dump into the lungs. So it will say, okay, give it to IVC. From IVC, it is the right atrium and the journey towards the lungs, right? Okay. This gives one more important point, and that is this right branch, right? When the portal vein divides, it is the right branch which is bigger, right? It is wide and short, right? And short, because this is that right lobe of liver is very near. The left branch, it is longer and narrower, right? With relative to each other. So that's what the portal vein will be doing. Rest is all fine. Splenic vein, and this is superior mesenteric artery, and this uncinate process, yeah, that is behind. You know it very well. This is the duodenum. D2, D3, they all are behind. Picture is clear. To see it with bit of more technicality, right? As such, to nothing technicality. It is such an easy thing, but sometimes the descriptions, they look more impressive. That when we are talking about portal vein, right? Then how nice would it look like that if we say, "Acha, which part of portal vein you are talking about," right? Whether it is before before duodenum, behind duodenum, or above the duodenum, right? Well, we feel, wow, wow, so technical. Then why not to give the names, right? So it is when it is said that whether it is infraduodenal, right? It is infraduodenal, retroduodenal, duodenal, right? AL, right? And then this above, that is the supraduodenal. At times I feel that this is a big advantage of being medico, because when you fight with someone, right, some non-medico, and you just speak these three things, that you don't behave like retroduodenal, otherwise I'll make you like supraduodenal, gone, right? He'll not fight with you, because these are the things, these are the words which look so scary. As such, it is nothing, but it is just this much. This one, right? This is infraduodenal. Then anything which is behind, it is retroduodenal, and this one is supraduodenal. What's the big deal in that, right? But still, it is like described. Okay, no problem. In the end of the day, make video on important topics for subjective exam points of view. No, I am not getting the point. Veins collect deoxygenated blood from organs, and that blood will go in heart and then lungs to the oxygenated. But why here deoxygenated blood is going in organs? Okay. Oh, Harsh. See, Harsh, I think this point we have talked at length. It is not so that deoxygenated blood is going into the liver, right? Portal vein is telling that, boss, I am least bothered with the oxygen. That's why I'm giving just 20% of the oxygen, 20-30%, right? The rest is given by hepatic artery. My work is to carry nutrients and the toxins from the GIT to the liver. So that's the thing. You got my point. So it is the porta hepatis which is carrying portal vein, which will be carrying nutrition. These nutrients, these toxins, these alcohol, whatever the person has consumed are to be todfod giri at liver. Liver would say, see, I need some money, and that money is nothing but oxygen. So hepatic artery will say, chalo, I'll give you that, right? And the liver starts working. Liver breaks it, does all the thing, it creates that bile. Bile is taken and stored into the currency chest, that is the gallbladder. And then the actual deoxygenated blood, that is actually which is carrying the carbon dioxide, that is given to hepatic veins. And those hepatic veins, they will be draining into IVC, to RA, to R, that is right atrium, to right ventricle. Then it will go to pulmonary arteries, and then it will go into lungs for the oxygenation. Got it? So it's not so that portal vein is carrying, why it is carrying deoxygenated. It is carrying nutritions, right? Whatsoever person has consumed, all those things they are carried. That's the beauty of liver. That's why liver has got a dual supply, right? But this particular vein, it is not so that it is an absolutely such vein which has got no oxygen. So that's why it is carrying some oxygen, right? But major function is to carry nutrition. Yeah, portal vein, it is going in liver. Now at this stage, don't ask this question. Huh? Otherwise, it happens like entire Ramayana is over and ye Sita kaun thi? Don't do that. Okay. So here it is, that point seen bit. So we can say for the working of liver and functioning of liver, some oxygen works. Obviously, oxygen is the currency for every organ. That's why we said that hypoxemia or the hypoxia, right? Hypoxia, lack of oxygen. Brain and heart, they are the most sensitive. And in brain, it is actually the medulla, right? Medulla is so sensitive because medulla's main function is that respiratory center. So if there is any any myocardial infarction, and if there is hypoxia, the first thing affected is the respiratory center. So that's the reason it is that time frame is so crucial. Else what happens that you do whatever you can, but it is of no use because that important center of the brain has died. And and any of the centers, any of the cells of the brain and the heart, once they are dead forever, right? They never recover. So this is the reason that at times on ECG you even watch that, okay, these are the evidences of old MI, right? You can see that because those tissues, they never recover. And that's okay. That's okay. There is no harm. You can always ask. But say at times you can always do one thing. You can anytime you can send a mail. So if you feel like that it is bit lengthy, right? If it's a long query, always send a mail. No problems. Okay. So over here, just watch this and this two things, right branch and left branch, and we said that right branch is moti tagdi, right? And I always think like that it is from khate pite ghar, right? So it is like shorter and wider, and this left branch, right? I marked it bit incorrect. I should have marked it here, right? So that is longer and narrower. And still, I would write one more thing. Don't forget that it supplies, right, caudate, which is irregular, quadrate, which is very disciplined, four sides, and plus the left lobe. I'm sorry. Left lobe, right? Left lobe of liver, and this is just the right lobe, right lobe, right? Rest is superior mesenteric, all good. One extra point, we'll see it over here, though we have talked about it, but it is the inferior mesenteric vein which will go into the splenic vein, right? So superior mesenteric, inferior mesenteric, and the splenic, right? These three. Now this is the intra-hepatic part. This thing is interesting. That portal vein, when it goes into the liver, now it divides, right? It divides into left branch. Now this is because we are watching from the back side, right? This is a posterior view. So your entire perception would be now reversed, right? It is ulta. So that's why this is the left side and this one is the right side. Okay. And here is the portal vein, and it will divide into this left branch and the right branch, right? Now over here, say there was one important ligament way back, we discussed it, right? One was ligamentum teres and second was ductus venosus. You remember that there was a falciform ligament, right? Falciform ligament, that gunda ligament, right? That falciform ligament, right? Is this is falciform ligament, right? I mean this shape. And this falciform ligament was having one border, right? One border which was very prominent, and that was like ligamentum teres, because it was carrying all those paraumbilical veins. And on the top, right, there was ductus venosus. Now what ductus venosus was? Ductus venosus was doing a very punya ka kaam during that fetal stage, right? Because in order to feed the fetus, right? Otherwise, liver was very petu, right? It was consuming entire oxygen, not giving anything. So that's why ductus venosus was doing a punya ka kaam to bypass the blood and take it all the way into the inferior vena cava, so that it can be, say, used by the fetus, right? So now once after birth, those things are not needed, so that's why it gets converted into all those ligaments, right? All right, okay. So regarding the tributaries, this is, I just put this thing because you should draw it 2-3 times so that it is very clear. right? Say always draw major vessels first and then start adding all those chota chota. So order: superior mesenteric vein, splenic vein. They both form portal vein. To that, just add inferior mesenteric vein. Then they will be dividing into right branch and left branch. So 1, 2, 3, 4. So I'll write 5 over here, 6 over here. So major things are over. Then, then we'll write say 6. Then let's finish this. Left gastric and the right gastric. So that part is clear that it will be coming from that portal vein. And only who is left out is this cystic vein, which will be from the right branch, and the superior pancreaticoduodenal, and this paraumbilical will be the last. If you draw it in this order, right, keep on doing it 2, 3, 4 times, then automatically every time you will draw it in this order and you will always remember. And when you really draw this, keep speaking certain things, right? Keep speaking certain things. It is like that it is this left branch. It is associated with what? Well, it is associated with that ligamentum venosum, right? Because it was at that point that ductus venosus was there, that punyakakam, right? So it was there. So it is at that point. And the splenic, it is splenic vein, it is for foregut, draining the foregut, right? Inferior mesenteric, it is for hindgut. It is for hindgut. And superior mesenteric, it is for midgut. One very interesting question was asked, right? I got that mail just before few minutes. As I was starting the session. So I haven't replied to that, but I'll reply it now. Right? It will take a minute, but it's a good one. And again, no problems for asking any of the question, but the question was very cute. Where have I placed that blank page? Yeah. The question was that why the superior mesenteric artery, inferior mesenteric artery, and the celiac trunks, they are not going into the liver, because in any case they will be associated with GIT. Now see, the answer of this question is, right, there is no harm, it's okay. But it is like, I'm happy that you asked this question, right? To make it simple, I'll just draw like this. This is GUT, right? This GUT is a living thing, है ना? And heart, and why I'm writing heart, then this is the thing. Heart to organ, right? Heart to organ, they are arteries. They carry oxygen. So from heart to this, right, they carry oxygen. So that this gut is now living, is working. When it is completed, right, it will be obviously putting its output. Everything would be absorbed and it will start traveling towards, right, towards the heart, right? So this is organ to heart, this would be the vein. That's where all these veins would come into picture. That is splenic, superior mesenteric vein, and the inferior mesenteric vein. But then they said that because they are carrying so much of cash, right? So this much cash, it is not advisable to take all the way to the heart. So that's why they say, chalo, let's go to liver, and liver will take care of this, right? So that liver is that's the reason that all of them combine together and they form portal vein, and portal vein will take them to liver. But liver will say, chalo, I'll process your entire transaction, but where is my pagar, right? Where is my salary? So this heart will say, okay, 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 I'm giving, right? So heart will give the salary to liver, right? And that is in the form of hepatic artery that is heart to organ, right? This was also artery, heart to gut, and then liver will settle everything, will convert, and will tell that, okay, gallbladder, right, you keep everything and just give them as needed, right? Done. And then liver is completing its job and sending this blood to heart. Okay, now this is carrying carbon dioxide, and that is via hepatic vein, right, from liver to heart. That's how the circulation goes. So interesting part is this. So don't be confused that why it is like, why the blood is not going straight away into the liver. It is going, but it is going only for the oxygen, right? While this portal vein is not carrying oxygen, though means there is some oxygen, but majority is nutrition and the toxins. And that's the reason that in case of portal hypertension, when the liver functionality is decreased, right, so these toxins, they will cross blood brain barrier and they will start attacking the brain. When it attacks the brain, technically we call it as a portal encephalopathy or hepatic encephalopathy. So in that case, there would be drowsiness, right? There would be drowsiness, person may slip into coma, there are tremors, all those neurological symptoms, they start developing. Got it? Okay. Finally, the areas, say this is like Portacaval shunt. So that's the first that leads to esophageal varices. That is where it leads to caput medusae. This is where it leads to hemorrhoids, right? These are the three areas where there is portal system and the caval system, they meet, and that's the point where things can break and can lead to bleeding. Okay, bare area of liver, that's the thing. Bare area of liver, this is the area where there can be portacaval, right? Rest are umbilicus, anal canal, lower end of esophagus, and some anterior aspect of kidneys. These are the areas marked for the portacaval anastomosis. This is easy, right? Inferior vena cava. There are several, because when we'll be studying portal hypertension in complete detail, right? Actually in medicine. So then we'll be learning even the treatment part, we'll be learning that how to manage, what are the surgical things which can be done. So that's where the shunt would come into picture. Shunt means we are diverting the blood from portal vein to the less pressure areas, right? So that things are improved. So that's it for today, right? Thank you so much, and we meet tomorrow, right? Thanks a lot. Take care and bye bye.